All right, so everyone, welcome to this week's COVID-19 Data Science Special Webinar Series at MIDAS. We've been running this series April, and we're planning to run this series till to sometime later in summer, July, or even August. This is because so many of our data scientists at U of M are doing very important and very timely work looking at the COVID-19 pandemic from individual patient treatment all the way to societal impact. Today's talk is given by two PIs and their team members. Zhenke Wu is assistant professor in biostatistics, and the co-speaker Veera, Baladandayuthapani, is professor in biostatistics and also the associate director of the Center for Cancer Biostatistics on campus. Zhenke, Veera, and their team members have been working on COVID-19, both at the individual patient level, predicting disease progression and outcome, and also using network analysis to look for, to pinpoint hotspots of in the pattern of disease spread using data from China and India. Both of them are active members at MIDAS, and Zhenke also is one of our core faculty members. So I will let Zhenke, sounds like Zhenke will go first. So I'll let him take over from here.
Actually, Veera will go first because I think you'll have interesting introduction first.
Yeah, so I just wanted to sort of basically set the stage, you know, of that was a very generous introduction, Jing, and I think you accurately hit on the point that, you know, we came together as a team. So I just wanted to trace the genesis of this work. And as you said, Zhenke will be speaking on part of the efforts he's been involved with, and myself, and also a couple of trainees, Rupam and Sharik, who are also on this call, who'll be chiming in with specific aspects that he's been looking at. So I guess that I'll go back a little bit to the genesis of where all this started, and this was a bunch of quarantine data science, and it was literally during the Ides of March that everything sort of closed down and put a halt to many of our endeavors, in-person endeavors, I should say. And then there was this outpouring of data from everywhere, from every possible source, that one can imagine. And I think that the talk was all about models. I think it was initially just a long list of prediction models, and then and being situated in a unique place as biostatisticians, plus being situated in a school of public health, I think there was an inherent feeling that this was our calling, and no more a better time to deal with this pandemic of such nature, probably the living generation has rarely seen. So the broad level goals we started to sort of think about, part of it independently and part of it together as well as a group, is just basically a very simple question: is how do we understand the dynamics of COVID-19? Just gonna gain a basic understanding. And I think the key aspect that we wanted to use is, if we get individual level data, which we did from to a certain degree, can we understand from that individual level data and use it to hit upon two main goals? And this is mainly motivated by a couple of data sets from China and India that we'll go into a little deeper here through the course of this webinar. And the two major goals that we were sort of looking at is looking at dynamic clinical progression of COVID-19, and specifically looking at clinical trajectories and how they can be used as a risk stratification tool. What's the first step towards a risk stratification tool? And Zhenke will speak more to that, and he has done some stellar work in that area. You know? And then we started looking at more network-based dynamics of COVID-19. And our key goal was just to get some more regional specificity and estimate disease hotspots and what sort of factors that might be attributed to that, but just gain an understanding. And our overarching, part of this process of understanding the dynamics is how do we actually, downstream combine with sort of these operational models of healthcare, not only understanding, as COVID-19, the evolving landscape of COVID-19, but even maybe in the future, what sort of things we can be thinking about, and we'll probably close by having some thoughts on those sort of aspects. So having said that, I'll turn it over to Zhenke now. To talk about the risk stratification modeling he's been actively involved in.
Okay, thank you, Jean and Veera, for the introduction. So I will probably use like 10 minutes tops just to summarize the work I've done. So a bit subgenesis of the work I have, why I started this work. So basically, in the mid-March, we are instructed to work from home, and there was one evening, actually quite late in the evening, I have to go to SPH to get my computers and everything I need for several months. And a friend called me, basically say, hey, I heard that you're doing individualized health and clinical decision stuff. Are you interested in doing some COVID-19 analyses using data from Shenzhen? So yes, yeah, why not? It turns out that for that evening, I was like, looking at data and thinking about these questions. So for about 1 month, and we were analyzing that data, pouring over that data, and I think this is the part of the work I'm going to introduce. I think the message will be that there are interesting findings based on that data, and also there are methodological questions we can answer. So on this slide, so Veera, should I ask you to go to the next slide when necessary?
Yeah.
Okay. All right. Yeah, this is currently fine. So, so one question was how to do risk stratification for the purpose of triaging. So, one co-author of the work that I'm presenting actually is a doctor treating patients. So they also always face very difficult triaging decisions. For example, do we admit this patient? Do we put this patient in ICU or not, right? So there are many decisions that needs data, needs knowledge about what's the risk of this person progressing into very severe stages. And even if now things have calmed down a little bit, this decision will still needs to be made during reopening. So one question is, if you're tested positive, during one of the drive-through tests, what would you do? Directly admit to hospital, or were you instructed to follow some other protocols? So currently I'm not clear about that, but I think there are lots of decisions regarding how to deal with new cases. And what's needed is actually individual level, temporal information about clinical progression and how they are associated with baseline and dynamic information. These are the first step towards creating the tool and hopefully integrating the tool in the electronic medical records system, so that the doctors who are making decisions will have access to these risk prediction tools on beside them. It's not to replace their own judgment, but to facilitate their clinical decisions. So next slide, please. So so to illustrate, basically we're going to use the data coming from Shenzhen. China is in the first country that COVID-19 epidemic has really got all of our attention. So the reason why we look at this data is because all clinical confirmed cases, including a sizable proportion detected through contact tracing, were required to be hospitalized. So no matter how, so the baseline is that, bottom line is that all the cases were admitted in Shenzhen. So this provides us with a data set that's quite clean, that's quite complete in characterizing the, clinical progression of cases, right? Without considerable selection bias typically seen in hospital-based studies, especially during the early phases of the outbreak in the US. And the data basically is comprised of like 420 patients between January 1st and March 10, 2020. And there are lots of information collected. So at the baseline, we have epidemiological information, demographic information. We will show you some of them. And over the course of the hospitalization, we have daily or twice per day laboratory measurements depending on clinician's judgment. And we have other clinical information. Basically, the doctors went into the room and record whatever symptoms they observed. And also there are chest X-ray information too. So all the information were updated until April 7th. And if you need more detailed information, the manuscript summarizing this is linked below is on my medRxiv. And just want to mention that all this data is collected by number 3 hospital, People's Hospital in Shenzhen, and managed cleaned by the Pencheng Laboratory. I think now is a key laboratory in China now, maybe because of some recent excellent work. So next page, please. So just to quickly introduce the concept, introduce how I think about problem. So in figure A, these represent different states. So people in biostatistics would call this a multi-state model. So if you look at the first row, these are mild, moderate. So these are the severity that you would normally see in this data, right? People come in with mild and moderate diseases. So, and then they can follow the arrow from left to right, transition to severe disease, and further into critical disease. So that means that the person would need to be sent into ICU. Normally that means you have to give them ventilators, right? And you can see arrows coming from arrows coming from the right to the left, right? So a person could, be better, after, some days of treatment in ICU, and then they can transition back to severe and transition back to mild, moderate state. So the two boxes in the second row are actually absorbing states, right? So that's the terminology to describe if you enter that state, you will never return. So if some people would die in the ICU, so that is the arrow on the right-hand side, and some people would be discharged after they have, either they did not even progress into the critical or severe stage, and they were discharged after a few days, or they actually were, they actually developed severe disease, critical disease, and then returned back to the left and then got discharged because they were mild disease at the time. So that describes the kind of the clinical stages, and that's the primary concept we're going to follow. In figure B, we have the laboratory measurements, and the time is hospital admission on the left, and I basically colored a timeline to be blue, representing that up until the right end point of the blue line, we have information about laboratory measurements. So I illustrated by 5, laboratory measurements here. So next slide, please. So these are the quick summaries of the data we saw. So there are lots of information on this slide, but I just want to quickly highlight that in the top right panel, so this means that if you calculate the cumulative incidence of ICU admission, so if you stratify by age and sex group, not surprising, actually now not surprisingly, that older males actually have, will enter ICU with a higher probability much faster. So next slide, please. So then we were basically trying to use this data to estimate few quantities that are easy to interpret. So what we did was to take all the data in and try to estimate at any time point after hospital admission, what's the proportion of cases in each clinical stage. And we were plotting the curves over a period of 80 days. So, so I like you to focus on the right figure. It's, I think, the favorite figure in this work. So in box A, basically you can see four curves, the one at the top and the curve in the middle on top of the yellow one, and the curve that's on top of the purple one, and the curve that's really flat. So from top to bottom, those four curves shows the time variant proportions of all admitted cases who have four different kinds of classifications. So the top one basically represents those people who have not been discharged, so they're still hospitalized and they have not died in hospital, right? And the second line represent those people who were in the severe state or in the ICU state or have died. And the third curve, which is the curve on top of the purple area, was the fraction of people who are in ICU who have died. And finally, the very flat one represents the fraction of people who have died at that time point. The reason why we did not see a lot of death is because these people were treated pretty early, and I think it's indeed is a relatively low mortality. And so this is for the entire set of cases, and we were wondering, can we stratify them into 3 subsets that can be called low, medium, high risk group. So what we did was using the existing method that's called random survival forest method to stratify cases into 3 strata. So we used the demographic information and baseline comorbidity and all the symptom profiles within 5 days of symptom onset, and also lab measurements within 5 days of symptom onset. So if you think about the blue time axis I showed you earlier, that length is 5 days. So, and then the outcome would be the, timing of transitioning into severe stage. So we just use that single clinical stage as a outcome. And then we were able to find that, hey, if you look at these 3 strata, indeed, one can be designated as a high-risk group because over time, the high-risk group will have a higher chance of being the severe stage. And if you go from the high-risk to low-risk group, you can see that yellow area shrinking, meaning that it is less likely to be in severe and critical stage according to the model's classification. So next slide, please. So on this figure, it is supposed to be representing all the important variables. So in the first row, for the figure on the left, we have plotted variable importances for a few lab results, and we have identified a significant drop in the PaO2, FiO2. I think this is like very common marker in like respiratory disease, respiratory infection. For other, factors I'm less familiar, but I think it is there for you to take a look at. And also on the right-hand side, we have the AUC calculations. So this value basically is calculated over time. So basically, it represents that if you use the information within 5 days of hospital admission, how accurate your prediction is in terms of predicting this person transitioning into severe stage. So the values between 0 and 1, the higher the better. And we can see this value hovers around like 0.75. So, and then, we did something that exclude lab value. Actually, the AUC are pretty similar. Next slide, please. So, there are some ongoing methodological work we're trying to carry out to fully characterize this model, because as you have seen, for simplicity, we have only targeted one single outcome, which is the timing of severe stage. But ideally, we would want to characterize the entire trajectory of, being in each of these states and also transition between states. So we will use multi-state model to do this. And also we were using covariate information within 5 days of hospitalization. And no matter how far in the future you're looking at. So an improvement would be that for any future time point, say 10 days or 20 days after hospital admission, can we use more information, like information up to day 10 or day 20, and draw a probability curve for any individual in a particular state at a future time point. So I think that will be helpful for predicting future events. So I will be, so next slide, please. So I think these are the technical aspects that I do not plan to talk in detail, but there are issues related to high dimensional lab measurements and time varying covariates. And I think I'm thinking about using Bayesian adaptive regression trees that has the capability of incorporating lots of covariates and dealing with sparsity. And also we are planning to use some simple methods called pseudo observations that can, readily deal with censoring issues. In our case, we do not have lots of deaths, but I think in common situations, we may have more censoring by death problems. And finally, we're going to use time-dependent AUC, as we have seen, to evaluate model prediction. So I think that's my current plan of extending the existing work. So I'll hand everything to Veera.
Yeah, thanks a lot, Zhenke. That's great. So I'll shift gears here and talk a little bit about the India case study that we have been looking at over the past couple of months or so. Now, India, as you may know, has one of the highest population rates, of course, but also highest density rates. So these are just 3 pictures from actually 3 major cities in India. Mumbai on the left, Delhi as of now on the top right, and that's a flower market in Kolkata. So I just want to acknowledge the group that came together for this work, from diverse areas and expertise. So the 3 of us who are speaking today, Rupam, Sharik, and myself. So to be honest, my role was more of a cheerleader here, and the quarterbacks for this work, were Rupam and Sharik. Did a yeoman's effort in this regard, especially Rupam. And so we had a collaborator who was sort of on the ground, Shanthan Banerjee, who's a faculty at Indian Institute of Management in Indore, who got us a lot of contextualization in the India-specific contextualization we needed for some of our models, and also the results for that matter. And that was very helpful to sort of interpret it in the right manner. And finally, Upali Nanda, who's a faculty here in the Department of Architecture, as well as works for an architecture firm, was instrumental in giving us a perspective on how do we move this to the healthcare, what are some of the burning questions, and also adequately place it, what sort of questions we should be asking and potentially be answering as we move through this pandemic. So, all right. So at the basis of our work was studying this from a network perspective, specifically contact networks. So I dabble a little bit in networks and in this domain, and I think it seemed a natural starting point to start understanding, the COVID spread mechanism, because inherently epidemics spread over a human-to-human network, especially infectious diseases such as these. And the basic tenet of how that happens is the carriers spread the contagion via contact, and this contact can happen at many different levels. So maybe due to social contacts, maybe professional contacts, and of course the travel related interactions that might happen. Okay. And one can use this framework as to build more realistic models for disease propagation using networks, and there's historical evidence of this, and the prime example being the case of smallpox, where healthcare policy, depending on some network-based analysis, could actually, zone in, especially in terms of the vaccinations, how they could, control or even eradicate some of the smallpox. And that's a fascinating story in itself, how actually the CDC from here was involved, in eradicating that in parts of Asia and especially India. Okay. So here's a simple, a simple simulation of a network, what we mean by a network, in this context. And what you see here is each dot, say, represents an individual, and then the network is sort of stepping across some time domain. And what's happening is the blue dots here represent the susceptible individuals, red are the infected ones. And eventually there is a recovery process that happens, so the green one. So as you step through, depending on the degree of connectivity of this network, you can see that there's these rates of infection and different attributes of this network can give a lot of information about how this network spreads. Okay, so that's within that framework. So that started some brainstorming of ideas and a coalescence of some ideas on how do we build these networks for India. So India at that point was reporting specifically through various channels, primarily the ICMR, which is the Indian Council for Medical Research. They were releasing some data, and there were a lot of groups working on making those data available publicly. So we looked at that data now at an individual level. So what you see on the left here is the map of India, where each dot here represents an individual person. And if there is a connectivity between these two, that means there is some link. And right now we took the spatial proximity as the link in these. So just for visualization, because if you put in all the links, it becomes too busy. So we just sort of mask some of the edges to make it a bit more visually appealing. But the basic idea is that the spatial proximity, given the density of India as it is in some parts, that there will be the human-to-human links due to spatial proximity and also due to social mobility. And okay. So the essential idea of to contain the spread is basically, at least through non-pharmaceutical interventions, say via lockdowns or social distancing or quarantining measures, is how do we break these links, and what can be done about this network system that can help us do that. What are the attributes of that? So and this may be very informative about the spread mechanism. So where the concentration of the networks are in terms of what are the the main hub nodes, those are called. So and then this can potentially lead down is having a more micro level specificity in understanding exactly at what regions there might be a surge or an outbreak, more focused outbreaks here. So this formed the basis of building a model on top of classic epidemiological models, typically known as SEIR models. And at this point, I'll turn it over to Rupam, who's done very deep analysis, and we'll talk more about the actual model construction and the model parameters. Rupam.
Thanks, Veera. So I hope everyone can hear me clearly. Just let me know in between if you can't. At first here, I'd just like to give you a brief background of what SEIR models are, just the simple versions of the SEIR model. So basically the idea is that whatever many people you have in the population that you are looking at, you break them into three compartments. One is susceptible, the people who can get infected in a future point of time. One is infectious, who are already infected and are potentially spreading the infection. And also there's a third compartment, which is depending on what resource you are looking at, it may be called recovered or removed. The basic difference is that when you were talking about removed, you were talking about recovered plus the deceased people. So people who don't have chances to get back to susceptible. And then these have potential variations as well. So for some cases, even recovered people can be again infected, but we are not considering that here. So if we can go one step forward, you will see the basic set of differential equations that describes this system. So the idea is that from the susceptible room, you go to the infectious room at a rate of beta per interaction between the one individual from the susceptible room and one individual from the interaction room. And because it's that per interaction thing, for the whole component, you need to multiply that with the number of people in those two rooms. So that's why that beta SI terms comes in. So that term gets subtracted from the change in S and gets added to I as a change. In I, the infectious compartment, now you get the removals. So that removals, recovery plus death, or just recovery, depending on how you are looking at your model, that also has a per person or per individual rate. So that is gamma. And then that, I think I made a typo when I wrote the last equation, which is a little embarrassing at this point, that S shouldn't be there, but that should be just a gamma I saying that that component gets added to this. And one important thing to note here is that all these things are in proportion scale. So all these are numbers divided by the total population, but you can also have a count version of this. So if we can go one step forward, we'll look at what is called the basic reproduction number of the system, which is just a ratio of the two transmission parameters, beta and gamma, which basically tells you at what rate the pandemic is really growing. So the main message here is that the higher this number is, the worse news there is for you in terms of the pandemic. So you want this number to be kept in check. And when this number is less than 1, that's when you basically know that it's smaller. And we'll see some variations of this as well. So the question is, how do you really go on incorporating network information in such a model which is based on counts or proportions only? So the idea is that you look at each individual as a node in a network, and for each node, you define probabilities of being in the 3 rooms. So being in the room S, room I, and room R, which sum up to 1, and then you model those probabilities for each individual I. So, and how do you bring in the network information? You basically build, as in usual graph theory setting, you basically build an adjacency matrix, which you will see an example of here, where you see multiple people are connected in different ways between one another. Now the example you see here is just a 1-0 thing. So the adjacency matrix only tells you whether they're connected or not, but you could also have different kind of like non-negative weights. And as long as the matrix makes sense in terms of some equations you'll see in the next slide, it's fine. We are, for this part, only looking at symmetric matrices. So we are not saying there are directional informations involved, but you can also have that. For example, like you can also have an infectious to susceptible link being more important than other links and things like that. So if we can go on the next slide, we'll see first a set of equations, which is a modified version of whatever you saw on the other slide. So now for ith person, you have those probabilities of being in the 3 rooms. So you modify the 2 equations at the end. So you modify the I equation and the R equation. And the modification comes in that part being highlighted in red, where you're basically saying that if there's a link from the jth person to the ith person, which is represented by the term Aij, then that person's probability of being infected contributes something to this person's probability of being infected. And then you aggregate that over the whole network. So that's what the sum is representing. And then basically after defining those 2, you define the third one in a way so that the 3 probabilities just add up to 1 at all time points. So that's how you set up this dynamic system. Now the question really is, how do you use such a system? So what is the utility of having such a set of equations? The idea existing in the literature is that you can, first of all, in the first equation where you see that SI, you can substitute 1 minus I sub I minus R sub I because of that third sum that you saw on the right. And then at the very initial time points when you can assume sort of like t going to 0, you can have that R component, the removal or recovery component, approximate to 0, because there's almost no chance of transmitting already to a recovery or death compartment at that point. And from there, you can actually get solutions in terms of the eigenvalues and the eigenvectors of A. And there's a whole lot of literature on that, which I'm not going into here, but there are some references that I've mentioned here that you can look into if you're interested. So how do you use that in the India context? So the idea is that you get the individual level data. So the data we are talking about is just like individuals who got affected by COVID, so just the infected people. You look at their information from which you can create a network. So it can be a location network, like the one you saw when Veera was talking about the initial network idea, or it can be a network of travel from one place to another, migration, and things like that. So for this talk, we'll only be looking at location network, but there are other options how you can construct a network. Once you have that initial network of infected people set up, you think about other susceptible people going around as just other nodes in the network. And depending on how close by they are and things like that, for which you can also get information from the population densities and other things of the region that you are looking at, you can construct that initial network. Once you have that, now you choose parameters for how this network will grow. So there are also ways where you can estimate parameters, but we thought that when we started this work, there was not really a lot of data that we had, and it may not be the case that the estimation would have been very reliable. So we just thought it would be more sensible to do it on a spectrum of values of the parameters, just to look at, say, from a very worst case end of the spectrum to a very best case end of the spectrum. So we kind of looked at multiple values of the R0, but specifically 3 representative values, 1.5, 2, and 2.5, which we call the low, medium, and high scenarios as of this. And then for that gamma transmission parameter, which has a relation with the time to recovery as an inverse as happens in an exponential setting, for that we chose a value of 0.1, so that the inverse of that is like 10 days. And that is like the mean time of recovery that's been reported for COVID in general. With that, because R has a dependence on beta and gamma both, you don't need to specify beta at this point. So with that, you can just let the network grow now. So we first did at a state level. So on this slide, what you see is based on data up to April 14, when I first made these plots for the states of India that had at least one reported case till then. What you can see here clearly, first of all, and that will be the case for both the future things that we'll be looking at, the medium and high scenarios, that there's always a clear separation somewhere down the line, after which you kind of can distribute the states into groups. So you can have some states that are mostly on the top, having a lot of cases, and then some in the middle, and then some in the bottom. That's how it goes. And that, again, that depends on how large the population of the state is, and also the population density and things like that. So if you go to the next slide, which is the medium intensity spread, here, from the previous one to this one, the difference that we will observe is that the rankings of the states are really changing within those sets. So if you look at, say, for the top 5 or top 6 states here, and the same in the previous slide, or even in the next slide in the high intensity scenario, the set of those states is mostly unchanged. The ordering between themselves may be changing. And that actually tells us a bit more about the pattern of this growth, which I'll talk about in a bit more detail. So again, now we can take a look at the high intensity scenario, which is just kind of the same thing. For some of the states, what happens is that because the recovery is happening also at a certain rate, and removal is also happening, so after a while, basically it reaches a peak and then goes down. That's what explains those turning curves at the end after, say, June 15 on those predictions. So now on the next slide, we'll be talking about how it did in terms of these predictions. So what we wanted to see as of this point is that whatever predictions we did based on, say, April 15 data, how do they hold in the long run? So you'll see a screen grab from the COVID-19 India data repository as of June 1, and you will clearly see that the top 6 states that I am showing here pretty much line up with what we are seeing there in our forecast. So if you look at the snapshots from June 1 from our prediction, that and this may have some disagreements in terms of the exact counts, but what matters is that we are being able to capture the pattern of growth of the pandemic in different regions. As a specific case, I'd like to look at one of the states, Madhya Pradesh, from where one of our collaborators, Shantan, is currently situated in. So it was great to have some context from him as well on this. There, initially, if you see, the green line is the actual observed data. The red line you see is the medium scenario, and the blue line you see is the low scenario. So if you see, initially, it was kind of growing at a rate comparable to the medium growth, but then as time is going forward, we are clearly seeing that the medium scenario kind of overpredicts in the long run. So that may be indicating towards the fact that the R0 that we were talking about has come down a little from past, but also may not be at the correct level where we expect it to be. Because if you remember, the low scenario had an R naught of 1.5, and something greater than that is still a risk. And also we had some other patterns in some of the states. So for example, there was an initial cluster of states like Maharashtra or Delhi, where there are a lot of international travel happening, people entering from other regions, other countries. And also there was a follow-up cluster that grew because of, say, interstate travel and public gatherings. So that's kind of the summary here where I will stop, and I'll hand it over to Shari here to talk about the operational models.
Okay, so so we have all these prediction models which talk about how the number of cases are going to increase and so on. But we were more interested in most of these models are telling us that there'll be a huge surge in the number of cases and so on. But how do we handle it when these cases go up? So our focus was more in the sense of, can we say something about the existing healthcare infrastructure in India, and how we can sort of talk about what we might need in the future depending on the number of cases which we'll see. So there's a lot of issues with healthcare infrastructure in India, within the states, and across the country as well. But one of the important things we already know is that majority of the Indian population depends on the public healthcare resources, as in the primary healthcare centers, the government-owned hospitals, and so on. So once we know that the disease is going to spread, if we want to sort of figure out what is the additional amount of healthcare resources you will need, that is going to depend on two main factors. One of the things would be, what are the different clinical outcomes of these infection as the disease progresses or as the infection spreads, and what is the existing available infrastructure you already have. So these are the two important factors you'll need to consider when you want to think about what is the additional thing you will need. So we got access to this data set from the Ministry of Health and Family Welfare, from the Government of India, which talks about the number of hospital beds at a state level across all the public healthcare healthcare centers, for example, the primary healthcare centers, the district level hospitals, and so on. So we wanted to make use of this information to sort of tell how each state would perform depending on what are the resources they already have. So we looked at this classical SEIR-based model where, so usually an SEIR model is categorized into 4 groups: the susceptible, the exposed, the recovered, and the susceptible, exposed, infectious, and the recovered categories. But this is a slight modification which basically divides the infectious categories into 3 different categories: the mild infection, the severe infection, and the critical infection. So the mild infection is those people or those individuals who have symptoms like fever or cough or some mild pneumonia, but they'll probably not require any hospitalization. Whereas the severe infection and the critical infection, for example, the severe infection is those people who will require some sort of hospitalization and maybe some supplemental oxygen and things like that. But a critical infection is those set of people who have a respiratory failure or multiple organ dysfunctions and so on, and may need to be treated in ICUs with mechanical ventilation and so on. So we can sort of build this structure with 3 different categories of infection and have these different rates of transmission or rates of transferring each individual from one of these categories to the other, and make some comments about what we might need in the future. So I won't be getting into the details of the estimation of this model, but I'll talk about, Rupam will talk about our app, where you can sort of work with these parameters and see how the results change. But our main results can be summarized here. So what we are saying is, on the right side, you see the plot of India and across different states, and the numbers on each of those states is essentially the additional number of hospital beds you will need within each of those states. when the infection when the number of active cases is at its peak. So that's essentially what these numbers are telling us. So as you can see, some of the important aspects from these results are that, for example, the two states on the top right of the map you see, if you can go to the next, yeah. So those two states which we have pointing there, Uttar Pradesh and Bihar, they host about 25% of India's population. So the number of hospital beds we sort of say additional hospital beds you will need in those states is also influenced by the total population of those states. But again, there's a lot of factors underlying there. For example, what is the already existing healthcare infrastructure? For example, Bihar has one of the lowest number of hospital beds per 1,000 people. The numbers are around 0.17 beds for 1,000 people. So all of those things factor in to sort of when we get these results. But one of the most hardly hit cities in India due to this COVID-19 crisis has been Mumbai. So we had these numbers for Maharashtra, which are talking about 45,000 additional beds you will require. But again, all of this data has been hard to get in terms of what is the exact number of beds available at a city level, at a district level, and also what is the number of ICU beds available, what is the number of ventilators available, and so on. But we'll talk a little bit more about what Mumbai has been doing in terms of getting these additional resources, healthcare resources. And of course, the other major city in India is New Delhi, where things have not been as bad as Mumbai, but now there's the lockdown in India is slowly being lifted, and people are worried about the huge surge which might happen in Mumbai, and what are the healthcare resources and the preparation of the government from that front. So one of the main things when we are looking at these models or these types of operational models is that even if you have the information of the existing healthcare infrastructure, the information about how many of, let's say, if you know that there's 100,000 hospital beds in a certain region, the information about how many of those hospital beds are actually open or can actually be accessed is very sparse. It's not easy to get. So we looked at different scenarios in terms of what percentage of hospital beds are already occupied. For example, the leftmost panel here shows in the case where you have only 25% prior occupancy of the hospital bed and hospital beds, and 75% of these beds are available, then most of these states sort of look well placed in terms of the additional resources they'll need. But if the hospital occupancy is about 75%, which is on the right-hand side, then almost all states in India need additional healthcare infrastructure or additional hospital beds and the associated infrastructure to be able to handle a pandemic of this size. So if you move to the next slide. So Mumbai and Delhi, Mumbai, of course, one of the worst hit cities in India currently, has been doing a lot in terms of adding additional beds and so on. These are two very recent reports on what has been done, especially in Mumbai city. And again, so one of the things I want to emphasize here is, again, the availability of this type of information as to what has been, how many beds have been added, how many beds, hospital beds, ICU beds, and so on. And recently, the governments have also started allowing private hospitals to deal with COVID cases so that the healthcare infrastructure could be boosted up. And the other thing we also looked at was when we are looking at these individual level data, there's a lot of susceptible population in India in terms of pre-existing conditions and comorbidities. So the plot you see on the right side is a word plot, which where the size of each of those words is sort of proportional to the frequency of the symptoms you've seen in these COVID patients. So, for example, diabetes, hypertension, and cardiovascular issues in India are very prevalent. So diabetes is 12% of the Indian population is diabetic, 30% has hypertension. Now, these numbers in terms of percentages, For example, 12% might not seem too much, but with respect to the population of India, it's about 156 million susceptible people. And for example, hypertension rates, it's almost close to the population of the United States. So considering these different types of comorbidities while you're planning to improve your healthcare infrastructure is very, very important. So these are some things which we looked at specifically in the context of the healthcare capacity, resources, and infrastructure. So I'll pass this on to Rupam to talk about our interactive dashboard, which we created to deal with different, each of these parameters and sort of change these to see what happens to these results.
Thanks, Sharik. Given we are running short on time, I was thinking I'll just whiz through the interactive dashboard. Rupam, I can speak to it very quickly if you're okay with that.
Yeah, perfect. No problem.
So basically, we have a Shiny, basically a dashboard which sits on a Shiny app that essentially does the 2 levels of modeling that we just talked about the state level predictions based on the reproduction number and the average days on an infected state, and another tab that basically uses the healthcare forecasting using the SEIR models that Sharik talked about now, and that has different parameters that can be put into it. So we just use default values that we learned from some reasonable default values, but those can be changed to look at different scenarios as well. So we first wrote a Medium article about it, and some of the local media did pick up on our work and hit upon different aspects that we talked about here today in terms of our work. So coming to something specificity, when we wrote the Medium article, this was around mid-April. We gave a list of recommendations, and I won't go through all of them, but just hit on some of the main points. As at that point, India was already past the containment mode. It was already going into a mitigation mode. Now, if you imagine in mid-April, the number of cases was still very low, but still at the rate at which it was going, we thought it was, that's where India needed to change strategy, and it did. There were a lot of good things that the government did or the local agencies did in terms of social distancing measures, the lockdowns, launching of digital tracing capabilities. And as we move forward, India is sort of on a peak right now. Is how can things be more smart about the quarantine strategy? And the 2 main aspects here were the migration and commute routes in India. That seems to be one of the critical things to look at, and also some super spreader events. There was one that actually there was a super spreader event in Delhi that sort of set the spark for some of the initial surge, but looking at other super spreader events down the line that might affect it. Right. So current directions, we sort of came to a screeching halt because somewhere towards the late April, India stopped reporting individual level data. So I'm not privy to what actually conspired, but apparently there was a ban on ICMR to report any individual level data. So, but the cases in India are still rising. So the plot that you see on the right here, you can see most of the countries here, top countries, the usual, with US being on the top, have a higher infection. Some are increasing, some are plateauing down, especially the European countries, but India is actually on a surge upwards. And so right now we're shifting a little bit focus away from actually prediction, because we're past that in some sense. Is looking at a deeper investigation of what happened. And what we are looking at in collaboration with an institute in India is looking at population density, what are the district level, which is equivalent to a county level here, attributes that might be affecting it, namely population density, urban versus rural versus tribal, migrant worker mobility, and possibly inform some precision mitigation strategies, maybe for this pandemic, for this wave, or maybe for the future waves. And that goes into combining epidemiological and statistical models, which we feel is something interesting in its own right, but very contextual within the current pandemic. So I'm going to skip over this because this is we're running short on time, and I'm going to leave at least some time for Q&A. Basically that's where that we are looking at. So, and also another future directions from a local perspective, rather, that's where Dr. Wu's and my group sort of came together, and been thinking about is how do we actually, look at these different aspects, both the temporal level aspect and the network level aspects, in what can we do. So looking at specific questions in medical triaging and risk stratification, and how can we do that, based on these different modes of the data, doing dynamic risk stratification, having an interpretable scoring system, as Zhenke, alluded to, and integrating electronic health records, so that we can just have better clinical and/or search models. So I know there's a lot going on within the university, and also consortium level effects that is part of, especially the COVID staffing projects that's led by Brian George here, and also through Michigan Medicine and the consortium of hospitals, the MI COVID-19 initiative that's come together to collect this data and look at community level data. So we ended our Medium article with this sort of summary line, and I think this becomes more and more pertinent in the current climate now. Is the strongest possible response to contagions is through building resilient communities that can manage contact networks. And something that I would really point out here is how can we do this, create a roadmap, for not only for India, but most of the countries, that something, the return back to normalcy can be in a phased manner that is socially responsible, equitable, and sustained. And it's never been as pertinent in today's climate as ever. So with that, we'll thank you all for your attendance, attention, and listening to us, and onwards we go. Okay, so I see on the chat that a couple of questions. One question is, Agrima, would you mind unmuting yourself and articulating your question so that we don't get it wrong?
Hi, thank you so much for the amazing presentation. I think what I'm trying to understand is that while you were presenting the Indian context, you did mention about the hospital beds that are there, and how increasing them has helped and getting in the private hospitals and everything. But I think I'm asking a more long-term question, in the sense that there's also an important statistic which comes into the Indian healthcare, which is the doctor to patient or the nurse to patient ratios, which is also bad. So now I do understand you can't just, overnight produce more doctors, but in the long term, when you're creating something, like this pandemic was a wake-up call in many sense. So, even accounting for those factors, that how do you improve on that? Because, God forbid if something like this happens again, or anything of the scale, there are other factors to be looked into, is I think what I was trying to ask.
Yeah, that's actually a very pertinent question. And that's exactly why, instead of even looking at, so we're starting with national level and digging down to a state level, but we actually need to go more focused at probably a county level, and maybe even more, because that's why the collaboration that we are starting with Public Health Foundation of India is getting those healthcare infrastructure metrics, is exactly what you talked about. Can we get those metrics and just understand what happened? We have these R values, these curves that have evolved over last 2-3 months, so can we just understand what factors affected it? And some places might have done a good job, some places might have done a bad job, and what are the attributes that might, come into it? And I think you hit the nail on the head, is what is the quantification of those factors, right? And some of them are readily available, some of them it's actually very vaguely available. And so that's why getting some experts on the ground and working, we've done that. So we are just taking one state as an example right now to start off with, which is the state of Odisha. Okay. And have some contextual knowledge. So we'll start with that, and then we see if we can grow outwards to other states.
Right, because I think the statistic is available about the doctor to patient ratios and everything. Might be an easier statistic. Like, I think these are published regularly about what it looks like for in the country. So that's, I think, where my question was coming in from.
Thank you very much. No. And I see another questions from Maya Bergman in accounting workplace aspects. And I can tell you, Dr. Palinanda, who's on our team, is actually a leading expert in that area, and she's doing a lot of interesting work in that area. And I would really encourage you to reach out to her on those specific aspects, how to using the built environment, how to look at the built environment and the disease spread. And I think there's very, very novel research emerging, that she's been involved in, and I'll be happy to connect you. If I interpret the question right, and if you, I can be more specific, if you can unmute yourself and articulate the question.
Thank you. You got it right. I appreciate your connecting me with her. I'm just really curious about ventilation aspects.
Yeah, and what will the new, the new built environment will look like post-COVID era? So, or within COVID era. So,
I think there's one question in the Q&A tab.
Did I miss one?
Yeah, it's not in the chat tab, but in the Q&A tab, which is just to the extreme
right.
Okay.
So I've been only looking at the chat tab.
Yep.
So the question is, how do we structure the model to take into account? That's a really good question. And that comes into what I was what we were alluding to towards the latter half of the presentation is getting that social mobility routes. Now, if we know that how the transfer happening between these different states, there are aspects, at an individual level that's harder. It'll be good to get data at that level, and we don't anticipate getting at that data level. So the best would be, incorporating something that can incorporate the, the changing of the, the networks as it happens, across these social, incorporating some factors that can incorporate these social mobility kind of factors. I'm a little uncertain about how to put that into a modeling context, but
yeah, I'd just like to chime in here with one comment, is that when we are talking about that network SIR kind of structure, if you have some sort of idea about how people are moving from one state to another or one region to another, even if you don't have very precise individual level information, you can have block structures in those adjacency matrices that we are talking about. And some blocks may have higher weights and some may have lower. That's how you tell that these blocks have more interactions between them and these have less.
Right. Any other questions?
So, all right. If no one else has questions, then we'll just thank the team for the wonderful seminar. And the recording of the seminar will be put on our website very soon. And if you guys have questions, obviously you should email the investigators. Thank you so much for the talk and for the wonderful work.
Yeah, no, thank you, Jane. Thank you, James. And please convey my thanks to Jag as well. No. Yeah. Bye-bye.
All right. Yeah,
Thank you.
goodbye,
Bye.
everyone.